Deep listening.
الاستماع العميق.
Deep listening.
Intensiv zuhören.
Deep listening.
Deep listening.
深度聆听.
Deep listening. Impact beyond words.
My wife was pregnant with our daughter Hannah at about 26, 27 weeks. And basically she said to me, the baby's not moving. Went to the obstetrician, said the baby's not moving. The obstetrician said, no, you're making it up, we'll get an ultrasound. Ultrasound guy looked at the 15 minutes, baby's not moving, but he just said it's a lazy baby. Next morning, my Sarah says to me, the baby is not moving, we're going to be burying this baby. And I rang the obstetrician the day before and said, look, I've spoken to my brother, who is an obstetrician in Sydney, we're not happy with this. And she said, but it sort of doesn't matter, because if we deliver the baby, you might be a high chance of that it might be impaired, or but we said we were prepared to take that chance. But she said, no, we'll just wait. And then the next day, Sarah had a stillborn baby. So she was really cross, and I was really cross that we would just not listen to. She was saying this is the case, and we would have looked after a disabled baby if that had been the case. We're relatively well off in the community, and that was huge, just a huge thing that struck me and struck Sarah, that she just was not listened to. And I get that all the time from patients when they say something was wrong and no one listened to me. And I'm sure that anyone who's had anything to do with the hospitals and healthcare and doctors will have the same issue, but thankfully it usually doesn't result in as bad an adverse event outcome as what we had.
Deep listening.
הקשבה עמוקה.
L'écoute profonde.
Deep listening. In this episode of Deep Listening, I have the opportunity to speak to a doctor. Michael's travelled from New Zealand to Australia and is equally passionate about the role of listening in the medical context. Listen out during this interview as he talks about his best athletics coach who taught him how to listen to his own body, and how his coach listened carefully to him to listen to the congruency between what's being said and what the body's showing. This helped inform Michael's later work as a medical practitioner. Listen carefully for Steve, the baby whisperer, as Michael says the most important thing that can be changed in the medical profession is the reform at the bedside between the patient, the doctor, the nurse, and the family. He talks about the fact that Steve had a cat-like observation of the nuances in the most infant children dealing with life and death issues, and making sure that interventions were timed appropriately based on listening and observation. Michael shares some very powerful personal stories. Stories about life, stories about death, stories about himself and his own family. And you can see why he's passionate about the power of listening and why it's required to transform the medical profession in the 21st century to patient-centered medicine rather than medicine-centered patienting. Let's listen to Michael.
Deep listening.
Deep listening.
Tiefes Zuhören.
Deep listening.
When you were growing up, was there a teacher or a parent or an auntie or an uncle or a grandparent or maybe one of your siblings that taught you a really interesting lesson about listening?
Well, I think one of the things I actually ran marathon for New Zealand universities, and one of the things that was really important was trying to listen to your body. This was back in the days when we didn't have much in the way of sophisticated training tools, and it was all about trying to listen to your body. and do that in an effective way so that you could train more efficiently. But I'd have to say that it's interesting that you should ask me that question, because I've only really come to the thinking about listening till very late in life. So I don't really have any strong memories of people that listened, other than my running coach, who was very good at listening and taking on board what we had to say about how we were going.
And looking back at your running coach now, what do you notice that he was doing really well in listening to you and the others?
Well, he had to take action based on what we said. So, and there's a fine line between listening in terms of I'm tired, I need this workout to end, as opposed to I'm overtired, and if I actually do finish this workout, it's going to damage me. And that's a very fine line with coaching, because the coaches who get that distinction right, of course, train better athletes. So being able to listen, and it's often sometimes not the words that are said, it's sometimes the non-verbal cues that you put out that can, so listening to me is a lot about, I'm just not listening to words, it's sort of taking in the whole environment and what's happening.
What do you think those visual elements and non-visual elements of listening that coach was doing really well, beyond hearing people like yourself complain that they were really tired and they couldn't really do another speed session?
Well, I think it's body language, and it's looking at the body language and seeing what if the body language is congruent with the words that are being said. And I think that's a hard thing to pick up. I mean, you mentioned the business about listening in relationships. Often that's actually looking at how the body language is as opposed to the words that are being said.
Very true. Michael, at university, what were you studying?
Well, that's a very long story, but essentially I finished my undergraduate medical degree and then worked as a house surgeon, and then worked as a medical registrar and intensive care registrar in Hamilton, and then had to finish my specialist training. So I went across to Adelaide Children's Hospital, where I did an 18-month stint in paediatric intensive care. And that was where I met a great sort of like the dog whisperer type of character, a chap called Steve Keeley, who was a very alternative lifestyle person who worked as one of the intensive care specialists. And he just had this unusual knack of being able to relate to babies and just calm them down and to understand them. And he was the one that said to me that, kids and babies are so different to adults. They can't tell you what's going on. And he said, you've got to sit there at the end of the bed and just spend time. You've just got to spend that time just sitting there, just watching them, feeling them, and just seeing how they're going along. And I took it when you say, who were the great listeners you had in the family and, university. Well, Steve was the first one that sort of got me thinking that you've got to actually spend time. You've got to spend that time at the bedside, understanding and getting a feel like the running, the body language. You just can't pick up on body language in a quick interchange with the person or a patient. So Steve was the first one that said, you spend time not at the computer at the main doctor's terminal, you spend the time out there sitting with patients and just observing them, and that's how you learn.
What do you think he was watching for at the edge of that bed, looking at these babies who were struggling to tell people what was wrong with them?
He was looking, intensive care is the specialty of cat-like observation and timely intervention. So whenever we do interventions in critical care, they can potentially damage the patient. You know, if we put a patient on a mechanical ventilator, they look as if they're life-saving on TV and it looks very dramatic. But that intervention of having to anaesthetise anyone to get the breathing tube into the lungs and then put them on a mechanical ventilator, you know, the data shows that is damaging. So it's a bit like the running coach. You know, you want to be able to time your intervention to when it needs to be done and when it can be done in a safe and competent fashion. And that's just sort of that clinical intuition. And Steve would just say that you develop that clinical intuition at the end of the bedside just by looking, sitting, talking to the mother, seeing what the mother says, seeing how worried people are, and just getting a feel in your own mind as to whether or not the situation's improving with the treatment you're giving, or if the treatment you're giving is not doing the trick and you might have to do something else.
Deep listening.
Deep listening.
Tiefes Zuhören.
Deep listening. Oscar has identified the critical skill executives need to lead effectively, but which is often forgotten in a world where our attention span is defined by 140 characters. Deep listening creates trust and authentic action for leaders at all levels and is crucial to the development and retention of talent. This is a highly valuable book.
Deep listening.
Deep listening.
Tiefes Zuhören.
Deep listening.
Thinking back to your university lecturers, I'm curious about the multiple lectures you would have had on listening, and the fact that, like most medical students, you had no lectures on listening. In fact, none of us go to school or university and have any lectures on any kind of listening. What do you wish, and what's your wish for future students in this intuition to be brought back into the education system of future doctors?
The problem with listening is that we all assume that people can listen. There's this assumption that that's something that we can do, but I mean, you clearly make a living out of the fact that we don't. And I completely agree with that in a medical context, that we don't teach people to listen. So there's two things. They don't listen, but we assume that they listen, and as such, we don't teach them how to listen. So, you know, a couple of my publications this year revolve around the fact that you actually have to take the students to the bedside, ask them to take a history from a patient, and then essentially almost sentence by sentence analyse and feed back to the students on what's being said and what's not being listened to. Because more often than not, you find that the patients are trying to give clues to the students or the junior doctors that are of relevance. But time and time again, you often see very important information being ignored by the students. And they ignore it because it's not part of their checklist. So we have this idea, and the students have this idea, that they've got to follow a checklist when they take a medical history, and that they'll pass whatever test or examination they'll have as long as they tick off the issues or the matters on the checklist. So if the patient brings something out of left field, like a result of a CT scan, I had a CT scan yesterday and it showed that I've got lung cancer, to the student that might be totally irrelevant on how they need to progress through their checklist. So concerningly, at medical school now, we by and large pass our medical students based on doing short activities in a test called an OSCE, which is for objective structured clinical examination, where the students get broken down bits of examination, physical examination or history taking or laboratory interpretation or tasks down to 5-minute tasks, and each of those tasks is often broken down to 20 points. So I've taken you rather quickly through what I think is a systemic problem, in that you've got a culture of social media. You've got this inherent belief that we listen, and we have a university examination system at medical school throughout Australia that we don't need to test your listening and intuition. We'll just test you on these OSCE stations, and that's how we're producing our doctors.
Deep listening.
Deep listening.
Tiefes Zuhören.
Deep listening.
Michael, if you had a wish and I could grant it, what would it be for the one thing that you could implement into either the medical system or the training of doctors that you think could make the biggest impact? And what do you think the cost of not listening is today for patients, for governments who fund medical systems and beyond?
Well, firstly, I would bring back the long case as a summative assessment. A student, before they graduate to be a doctor, should be assessed on their ability to sit down with a patient over at least 30 minutes and take a history, which is asking questions and listening to what the patient says, and perform a physical examination and then put all of that information together. That's the one thing. I would not graduate people if they could not do that to an appropriate standard. And that's the way I had to pass graduate when I graduated in 1983. And there's various reasons why that's gone, but if you're asking for the wish, I would say that would need to come in, because then it would force the students to have to go out, like when I was talking about Steve Keeley, he said you've got to get behind get away from the computer, get away from the doctor's station, and go out and sit there with the patients. So there's that theme that I'm talking about. Trying to measure the cost. I mean, before we went on online, Oscar, you mentioned the Mid-Staffordshire inquiry, and a big part of my research has been patient safety and what goes wrong in hospitals. There is no doubt that at an individual level, when I look at adverse events where I work, and I've even had medical adverse events myself, as has my wife. There's been an Australian story about that. In both of our adverse events, the situation was quite simply that we were not listened to. We're intelligent, we know what's going on, and we were not listened to. So God knows what it's like for other patients who don't have doctorates and doctors and, who are highly educated. They just get ignored.
Deep listening.
Deep listening.
깊은 듣기.
Deep listening.
For those of us who maybe are listening and haven't had a chance to hear about the Australian story and your family examples, I think it'd be a great opportunity to share those with our listeners.
Well, just briefly, back in 2008, my wife was pregnant with our daughter Hannah at about 26, 27 weeks. And basically she said to me, the baby's not moving. Went to the obstetrician, said the baby's not moving. The obstetrician said, no, you're making it up, or we'll get an ultrasound. ultrasound guy looked at the 15 minutes, baby's not moving, but he just said it's a lazy baby. Next morning, my Sarah says to me, the baby is not moving. We're going to be burying this baby. And I rang the obstetrician the day before and said, look, I've spoken to my brother, who is an obstetrician in Sydney. We're not happy with this. And she said, but it sort of doesn't matter, because if we deliver the baby, you might be a high chance of that it might be impaired, or but we said we were prepared to take that chance. But she said, no, we'll just wait. And then the next day, Sarah had a stillborn baby. So she was really cross, and I was really cross that we were just not listened to. She was saying this is the case, and we would have looked after a disabled baby if that had been the case. We're relatively well off in the community, and that was huge, just a huge thing that struck me and struck Sarah, that she just was not listened to. And I get that all the time from patients when they say something was wrong and no one listened to me. And I'm sure that anyone who's had anything to do with the hospitals and healthcare and doctors will have the same issue, but thankfully it usually doesn't result in as bad an adverse event outcome as what we had. But then 3 months later, I'm actually having a laparoscopic appendectomy, and it's a long, complicated medical story, but briefly, I was bleeding after the event, and I was assessed by a system of care called the Medical Emergency Team, who said, no, you're having an acute myocardial infarction. And I said, no, I'm not. I'm a former athlete, as we've just been talking about. I haven't got chest pain. The ECG that you're looking at is unchanged from the one that I use from tutorials, but again, not listened to, and was sent to the cardiac catheter lab and given anticoagulants, and essentially nearly bled to death until I said, you've got to take me back to the operating theatre. And I had to use the forcing function to be listened to, so I had to use the F word, get the effing surgeon. And with that use of that forcing function, the staff listened to me, rang the surgeon, and when they opened me up, I had about 3 litres of blood in my belly. So to me, again, not listened to. It was rather dramatic to me. And then from 2008, I thought, from now on, I am just going to spend time with students teaching them how to listen. And that's how I've come about with the research and publications that we've published this year on teaching students to listen and getting them to focus on the real issues that the patient's saying.
Michael, thanks for sharing that story. I'm sorry for your loss.
Thank you.
Deep listening.
Écoute attentive.
Penne ascoltare.
Ukulalela fieleja.
It makes the cost quite real. And when you multiply that by the number of patients that move through the medical system, I can hear many doctors saying, but you don't understand the pressures we're under and the funding on which and the reports we need to create and the outputs we're expected to achieve and the quality standards that we're held to. We just don't have time to listen, Michael.
That is just absolute rubbish. Let me give you some examples. Just recently, I referred a patient, or recently I was looking after a patient, and it turned out that I had to do a chest X-ray. And then, there is a lung cancer. And I talked to the patient, and she said, yeah, listen, I sort of knew about that 2 or 3 years ago, and I was seeing a respiratory specialist, and I just sort of didn't get followed up. And I thought, well, that doesn't sound very good. But then she said, but look, I don't really want you to do anything about that anyway. So I said, are you sure? And I said, well, look, we should probably be a bit more certain about this. So I'm happy to do a CT scan, but we won't. I'm taking on board that you don't want chemotherapy, radiotherapy, or surgery. So she said, all right, I'll let you do that. Okay, so do the CT scan. Comes up with sure enough with lung cancer. I then say, family then want to get involved, and the family are a little concerned that they would at least like to think that mum might have the appropriate operation, query chemotherapy, query radiotherapy. But she's adamant that she doesn't want that. So I say to the family, all right, well, let's make a compromise. Let's just get an opinion from a respiratory specialist. So I sent her off to another specialist, proper respiratory specialist. I'm just a general physician in this context. And I say to the guy, look, she doesn't want anything done. She doesn't want operation. She doesn't want radiotherapy. She doesn't want chemo. But the family would just like to also hear that from you. Anyway, I see her the next day. Say, how did your appointment go? And she says, well, to be honest, I'm not very happy. I'm been booked on a list for a bronchoscopy. He's ordered another special sleep study test for me, and I just want to be left alone. And I know this will make me pass away, but that's the way I want it to be. So, essentially, the traditional specialist wanted to go down the pathway of doing all the right things for the patient, which costs money, costs a lot of money in the healthcare system. And I see elderly people all the time with similar stories. They don't want to have the chemotherapy, the radiotherapy, or the surgery in a lot of situations. And we don't give them the options, and we don't listen to their thoughts about this because we're too busy to do that. But we're all very happy to spend 3 hours doing the procedure and billing them for that, and then putting them through elderly people through very onerous radiotherapy and chemotherapy schedules without listening about whether or not they really want this. Because we don't have the time to listen to them for all those reasons that you have just said. But if you turn that on its head, and if you actually spend that time having a decent chat with the patient and the family and working out what they really do want and putting to them what one of the, my son's got ADHD and I've learned that I've got that, and the critical thing that I write about is asking the thoughtful question. And the thoughtful question of these patients is, do you really want to go through all of this? And in so many times when I ask that thoughtful question, the patients are so relieved to have someone who's on their side listening to them and advocating for what's the best way forward.
Given the effort you've gone to undertake the research and build this body of evidence, what are your major findings from the research?
Well, the main finding is that students, and there's data and research to support this, are driven by the summative assessments. So we as educationalists have failed them. If we set the goalpost of to get your medical degree, you have to do A, B, C, D, and E, that is exactly what the students will do. So it is not the students' fault. It's those of us who designed the curriculum and who have to take responsibility for that.
Knowing it's a microeconomic reform that needs to take place at the bedside, what does your research tell policymakers about that?
I don't think I've got much of a message for policymakers. I think the problem with healthcare is that we're too much into macroeconomic reform, changing how the health system looks and runs, as opposed to focusing on what I call patient-centred care. And we just need to look at how general practitioners are continually squeezed on their the way they're remunerated, by virtue of the fact that we're stuck in a model of fee for service for a lot of medical services. Sitting down and listening to a patient doesn't get much remuneration, whereas if you don't listen to them and take them straight to the operating theatre and do a 2-hour operation, the remuneration is generous. And when we look at the work that's being done with Safer Care Victoria, look at the work with the Francis report out of Mid-Staffordshire, time and time again, we see that it's how those things operate at that microeconomic level where we have a failure in the culture of the workplace, for want of a better word, that leads to these poor outcomes. So no one has really grappled with the situation that it's microeconomic reform that we need to have. I'm sort of like a sole voice in the wilderness, not being listened to.
The irony's not lost. The irony's not lost on me at all. Michael, are there other cultures or countries that are getting this right?
Well, it was interesting. I spoke at the Ramsay Health conference up in Brisbane. It was, and again, it's lovely when these people invite me. I donate my speaker fees. And the woman who was on before me was, I can't remember her surname, Jane, who is the CEO of Jetstar. And she spoke a lot about the culture within aviation, which struck me and how it's changed. And I thought it was a very patient, customer-focused and also worker-focused environment that they strive for every day on every flight. And one of the example that she mentioned was that when there's a potential problem or adverse event, the pilots stand themselves down. And so when this problem is solved, I'll go back to flying. But then the organisation supports the pilots, support the system, look at what went wrong, fix the problem, and they turn that around in 2 weeks. I mean, for health to do that would just be, if any of your listeners are in health, they'll know exactly what I'm saying. So I think we can, there are cultures where that, we see that working really well. And I'd have to say, listening to the CEO of Jetstar, clearly that's something that they strive for and continue to work to a higher level with.
Deep listening.
הקשבה עמוקה.
L'écoute profonde.
Deep listening.
Michael, if we think about the main pillars of your research findings, are there any others you'd like to share with our audience about the importance of listening?
Well, it was interesting when you said at the very start that you can improve your personal relationships. And I often say at the end of my talks, I try to give the audience something to go away with, that there's something that they can do now to improve what they're doing in their organisations. And then I jokingly say it'll also apply in your personal life. And I say, just try this. Just go home and say to your partner, wife, husband, boyfriend, girlfriend, whatever, child, and just ask them a thoughtful question and listen to what they have to say. So rather than saying, how was your day, and getting the response, fine, and then you can go and watch the TV, why don't you ask, what was the best part of your day? And then the respondent has to give more than one word and more than one sentence. And then you can ask, well, what was the worst part of your day? And before you know it, you're actually having, because listening is about conversation, it's about, I often try to, in my tutorials with the students, say, and I've done a lot of this in this interview, I've been the one who's been mouthing on. I haven't been listening to what you've said very much at all, Oscar. And we know that when you're dating, that such people are quite boring. We also know that when you are the one, they're quite boring, but when you're sort of hitting it off, when there's an equivalent level of verbal communication and listening that goes both ways. So ask a thoughtful question and listen.
I'm curious how those thoughtful questions translate into the context of your tutorials, and I'm just wondering, what are the characteristics that you teach these students about thoughtful questions from a medical perspective?
Well, I think the first thing is that often when we're giving a medical interview or taking a history, it's quite didactic and checklist. And I think if someone has, to use the example of the fictitious example of someone having the lung cancer, asking the patient how they feel about that. What do you really think about this? That can often give you very early and useful information about, potential therapeutic strategies. Because when you think about it, all of us have thought, I'm not saying that we're all depressed, but all of us have thought somehow about how our lives might end. And when you sort of pop the question or statement that there's a lung cancer, often it's interesting that the patients might say, yeah, I've always thought that there might be something like that. And I've already thought through how I want you to manage this, doctor. Do you know what I mean? So it's a case of using the listening to get on the real level with a person. And that's why I use the dating analogy. Where if you actually listen carefully and then respond carefully to that, you can very quickly get onto a level with the patient that really has you thinking about, what does this person really want? What do they understand? How can I help them? And where do we go from here?
Exploring what's unsaid is quite often the most powerful thing my clients say to me makes the difference in their listening. How do you help your students, or how do you yourself explore what the patient isn't saying?
It's those clues. And there's some, I've cited a few of the research. It's looking for the clues and keeping your mind open for the clue. I don't know if you're a rugby fan, Oscar, but, often in the days when I played rugby, you scored tries, and that was because there were big gaps in the defence and you just ran through them. In this day and age, defence is so well organised that you've got to make and build on half breaks, and then you score a try. Now, we love it when there's those beautiful bits of free-running rugby that result in tries. But history taking is like modern rugby. You get a bit of a half clue from the patient, and you've got to follow up on that clue and then follow up on the next clue they give you. So it's a case of being like a detective, and the patients often only give out half clues. The disturbing thing I find is that all too often, and we can do it so easily, is that the half clue is shut down or ignored by the student doctor or the junior doctor or even the senior doctor. It's just dismissed. It's not relevant. And yet often the patients don't know really what they're talking about. They're not that stupid either. And so they offer up the half clue, the half break. And the art of listening is to be able to say, well, they've mentioned that. Just how is that relevant? Maybe I need to ask another thoughtful question. And then you might get another response from the patient, and it doesn't still add up. So what I try to say to the students is that if it doesn't add up, still stay with it. Pursue the issue.
Michael, take us to the bedside and help our listeners come to a place where you're in front of that patient. What does a half clue sound like?
Well, to me, I think first of all, the half clue, as you said before, is often things that aren't said. And often it might be things that are said right at the end of the consultation or the by the way, doctor, I've got this problem. And of course, because you're now out of consult time when you've got the next patient or patients waiting, you just sort of totally dismiss that or just say, well, we'll talk about that next time. So the first thing that I think one of my main strategies is to try and maintain a normal, friendly conversation with the patients. Keep it informal. And try and be on the lookout for clues, because I don't think we teach people to look out for the half break, the half clue, and then jump on it or follow it up. So how it looks is that it's often unsaid things, but often the patients offer up quite a substantial bit of bait, or often it's more than a clue, often it's barn door. That's what disturbs me, is that when we look at adverse events, often when we go back through them, it's not a clue that the patients were putting up, it was an open barn door, and it just got ignored. So it's not so much about being cleverer or cleverer listening, it's about not shutting out information that you're given and viewing it as irrelevant. But often patients will say, I'll give you an example, we'll stick with lung cancer. They say, they'll mention to the student, you say, why did you come into hospital? Well, I needed to come in because I had a CT scan yesterday. And the student will go on with other questions. And then I stop them and say, okay, the patient had a CT yesterday. Why did you not ask them if they knew the result of the CT? Because I didn't think to. Or I will ask the patient, do they know the result of the CT scan? Okay, so the student asks the patient, what was the result of the CT scan? And then often the patients have been told quite quickly after the CT scan what the result is. And the CT scan result could be that they had lung cancer. But if the student hadn't actually followed up when the patient said, why did you come here? I came here for a CT scan. Now, you or I might think it's totally reasonable that we should then say, do you know the result, or has anyone explained to you what was going on with that? I kid you not that more than half the students that I would look at would just go on to the next question and totally ignore that clue that the patient had a CT scan yesterday. And that is because they view it as cheating. That if they ask the patient if they know the diagnosis as students, that it's cheating to go all the way and to get the answer so early on in the consultation. But I say, no, that's fine. If you get the answer that they've got lung cancer, you can then escalate the level of conversation to one that relates more to how you feel about this, what would you like done about it, what do your loved ones think about it. So you can get onto a more meaningful level. If you look at all of the inquiries into adverse events, it boils down to poor culture. Often that poor culture revolves around a lack of respect. When you have lack of respect, you don't listen. So and I get back to our dinner table in New Zealand just to sort of close the loop on all of this. Everyone's had way too much to drink. Everyone's actually really having a good time, but we're all just mouthing off. And no one's really listening. So I sometimes think hospitals are a bit like that, and I think about Steve Keeley and the way that he would just spend that time just sitting there doing nothing, just taking it all on. And we need to reteach that.
Deep listening.
Deep listening.
Tiefes Zuhören.
Deep listening.
Michael, as we come to the conclusion, one of the things I'd love you to help our audience understand is you've referenced Mid-Staffordshire a couple of times in the dialogue, and most people probably aren't familiar with the systemic issues that happened in that healthcare system and the huge costs. Could you draw a line and help the audience understand what were the findings of the inquiry in the UK in this area health service and what's actually changed since the findings?
Mid-Staffordshire was about a trust hospital in the United Kingdom that eventually was found to have a culture of bullying, substandard care, and poor patient outcomes. Now, the interesting thing is that Mid Staffordshire was what was called a foundation trust hospital. So it was considered by all the measures that we look at hospital systems to be a high-performing hospital. So they were allowed to operate somewhat independently. And all of this would have gone unchecked if it wasn't for one woman who I had the pleasure of speaking after or just before at a conference called Risky Business in London a couple of years ago, who blew the whistle on the fact that her mother died there. And she was really unhappy, not only with the way her mother was treated, but the fact that she repeatedly wrote to the hospital, she repeatedly wrote to members of Parliament, she repeatedly wrote to the Minister for Health, and essentially, no one responded, listened, or did anything about it. My take on all of that, and bearing in mind we just had the Baker's Marsh issues in Victoria, are that we keep seeing these, students of these inquiries like myself, we keep seeing them. And that is because the governments and healthcare systems undertake macroeconomic reform. And we need to spend more time doing microeconomic reform, which is spending that time with the junior doctors, junior nurses, creating the right culture at the bedside. And a big part of that culture is just listening to the patients, patient-centred care. And I'd just like to reiterate that we just need to, I haven't said this enough, but I think if we treat our patients as human beings that do understand their bodies, they're not stupid, and they often have something sensible to say, and we should be listening to what they have to say.
What a great place to finish. Michael, thank you.
My pleasure.
Deep listening.
Deep listening. Ku yingisela swinene.
Kukai kikitori.
Deep listening.
I'm not sure about you, but listening to Michael with Johnny in the studio, we were both visibly shocked when he was telling his stories about the cost of the medical profession not listening for him personally, for his family, for the child that he lost, and for the many other examples where listening wasn't happening. It's the first time I really had to pause during an interview and collect myself to stay focused in the interview because I was visibly shaken by him telling these two stories. I was thinking about how much blood 3 litres of blood is, and I was visualising 2 litres of orange juice and then realising there was still another litre to go, and imagining what that would look like inside somebody's body and the pain that must be causing for them because somebody wasn't listening to them. I'm excited that Michael's on this journey, and I'm excited by his research to bring evidence around the cost of listening. I'm excited by the role he plays in helping students understand how to listen in that simple, skillful technique that says, ask the thoughtful question. For each of us, as we listen to Michael and to honour the child that he lost, I think that's the gift we can take away from the conversation. How can we ask the next person, or the person we're in conflict with, or a person we might not even know, a thoughtful, skillful question? Those who don't listen to history will repeat it. And whether it's Staffordshire or Bacchus Marsh in Australia, the medical system continues to repeat these mistakes because they're not listening. But there is a flicker of light in the examples that Michael talked about. He talked about the fact that they can look to the aviation industry as a great example of an industry that listens and learns from its mistakes and supports its professionals during the process of learning from that. Let's hope this can be applied to the medical profession in the 21st century. Otherwise, the cost is not worth thinking about. Thanks for listening.
Deep listening.
Deep listening. Lord Lascelles.
Deep listening.
Deep listening.
Whakarongo pohonu.
Deep listening. Impact beyond words. Hi, it's Oscar again. Thanks for listening to the podcast series. We think it's the people we interview that make the biggest difference in helping the world to listen deeply. We're always on the lookout for great role models of listening. You might know them. If you do, it would be great if you'd like to introduce them to the podcast series. Simply send an email to podcast@oscartrimboli.com. That's podcast@oscartrimboli.com. Or they can visit the website oscartrimboli.com/podcast interview, where all the details of what's involved is listed out there. Who knows? That great listener just might be you. Thanks for listening.
Deep listening.
Deep listening. Lord Lascelles.
Deep listening.
Deep listening.
Whakarongo pohonu.
Deep listening. Impact beyond words.